Well, good evening. This is Medical Insurance Billing, Myth or Magic. This webinar is informational and should not be relied upon for exact medical, legal, or billing decisions, as this is an international webinar. There are many intricate rules when it comes to medical or dental care and billing. You need to check your governing board on your district's rules, regulations, and standard of care and billing issues. We will be generalizing for this webinar, and some ideas, concepts, and guidelines may not be applicable for your area. Welcome. I want to say thank you to Keller Labs. Keller is the sponsor of this webinar, and Keller is a full-service lab. They do Crown and Bridge, partials, NTI. They do the EMA, the TAP, and of course, they deal with free shipping as a full-service lab. They are always knowledgeable, and if you talk to the Crystal Clear department or any department at Keller, they're just fantastic to deal with. My name's Larry Twersky. I'm going to be one of the hosts today. I am the founder and CEO of 1-800-SNORING and 1-800-SLEEP-MED. And my dad had this problem growing up of sleep apnea, and as a child I remember having him come home right away and just wanting to fall straight asleep because he didn't have the energy. And then as soon as we started to watch a movie as a family, he snored like you wouldn't believe. And it got me very interested in this. I'm also on the board of Oral Health America and their big galas this next week, and a member of the Periodontal Coalition, past president and officer and shareholder of 1-800-DENTIST. And again, I've been interested in this for a while, and so let me start with medical billing. When coding and billing Medicare or medical insurance for services rendered, there are certain guidelines that must be followed. And if these guidelines are not followed, the ramifications are staggering. And so today with us, I have Ms. Rose Neerman. Rose is the president and CEO of Neerman Practice Management, dental writer software, 30 years of experience as an RDH and dental office manager, created Dental Writer and Crosscode and Medical Exam Express software. She's an author, contributor, and lecturer on numerous medical and dental topics and publications, and has spoken in many venues, way too many to mention. She is somebody who I turn to for a lot of medical and billing questions, and I'm so happy to have you on the line with me today, Rose. Thank you for joining us.
Well, you're welcome, Larry. Thank you so much for having me, and welcome everybody.
And I have heard you've been called the queen of medical billing, so if I refer to you sometimes as Your Highness, I will just go with that.
That's just fine.
Okay.
Thank you. Thanks so much, Larry.
So let's talk about some of the challenges today that we have in for dentists billing medical insurance.
Well, we do find that if the dentist can bill medical, more patients will accept treatment. You can even lately, if you pre-authorize claims electronically, find out in advance whether or not sleep apnea will be paid through medical. Other challenges are training for dental teams. There are a lot of differences between medical and dental insurances. So, that's something that we try to help out with as well. Another is, go ahead, Larry.
No, go ahead. And
Okay.
again, one of the biggest topics we're going to talk about is how they're going to get paid for what they do, because over and over, the reason we've got so many people signed up for this webinar is because of they need to know how to get paid. And it says documentations for medico-legal purposes. Is that a Roseism?
That actually is. When you're billing medical, you want to make sure everything is legal, and so I came up with the medical legal term. And it's just so important. You'll see when you're billing medical, the documentation is even different than billing dental.
And we've got a lot of slides on that. I think we've got about 70 slides to cover, and I just want to make sure we go through some of them today. So what we're going to cover today is we're going to define the types of codes used in medical billing. We're going to cover medical insurance fraud versus dental insurance fraud, because it's so different that I think it's really important to kind of cover. And then we're going to talk about what's medical charting is versus dental charting and the documentation. And then let's talk about the process of charting, servicing, billing, and then waiting for payment. And then let's get into some medical codes, and then again, potential ranges in fees. It's not going to be that we're going to talk about exact fees, because that breaks into antitrust rules. but we can talk about some ranges because we get asked so often about what the doctors think some of those costs, what those fees range should be. So, Rose, take us through some typical codes and what these mean.
Okay, well, CPT codes are just like your CDT dental codes. They're the codes you use for the actual procedures that you do, and that would be used to report the exam, the x-rays, and the oral appliance, that type of thing. HCPCS, Healthcare Common Procedure Code System, that's a second level of CPT codes, and we'll explain those a little bit, but those are medical billing codes.
And what's the acronym for that you always use?
The HCPCs.
HCPCs. So
that's how it's pronounced. HCPCs, yeah. And that's not a Roseism. That is how it's pronounced. HCPCs.
I didn't mean, but I know that we use the term in there. I just want to make sure everybody hears it when we start using the term HCPCs.
HCPCs, okay.
We're referring to that. And
then the ICD are medical diagnosis codes, such as for sleep apnea, TMJ disorder, severe bone atrophy, that type of thing.
Okay, and then when we see the ICD-9, it usually stands for what revision? We're on the 9th revision now?
The 9th,
And then CM stands for clinical modification. So if anybody's ever wondering what those means, you now can win Trivial Pursuit on this.
Now you know. Okay, these are the CPT codes. These are put out by the AMA, and it describes the medical, the surgical, or the diagnostic test that you're doing. And it's just, to make everything uniform. Just like we have dental codes, we have the medical codes.
Okay, and it should be noted that, when we're talking about CPT codes, that it's uniformity and understanding what the service is, and it doesn't necessarily mean how you're getting reimbursed, because we're going to get into a section where we talk about what codes mean, what you're going to get paid for. So the CPT code is really just what was being done, not how much it costs to be done.
Correct.
And as an example, we look at here, an example is Dr. A might perform a referring doctor exam, and the code would be 99243, and might get reimbursed $300 by insurance X, and Dr. B might do the exact same thing with the exact same code and only get $200. And again, this is not the same for Medicare, and I think you're going to cover that in a few minutes. Medicare uses the HCPCS, right?
That's correct.
So
and we'll be talking about private medical insurance companies and Medicare, and they are two different things. So I'll try to point out when I'm talking about private medical insurance versus Medicare.
Okay, and just so you know, Rose, we're getting a bunch of questions here.
Okay.
It's, we're making sure that we're going to go through some of the questions. I see some people asking them, and we're going to try to get to that at the end. We're probably going to run a little bit late so we can leave some question and answers. And what I forgot to mention earlier is that we have a few offers at the end of this webinar for people attending. Keller has offered some specials for some services that we offer and some that they do. So we're going to get through those too. So let's go through the two levels of code here.
Okay, the level 1 are your regular CPT procedure codes. Your level 2 are what we were talking about, the HCPCS codes. That's what Medicare uses. And a lot of private carriers are now using them too. And these are codes, alphanumeric, that are for, say, CPAP, scooter store, wheelchairs, canes, and prosthetic devices. And those are the codes you'll be using for sleep apnea appliances. And because a dentist is considered a durable medical equipment supplier when it comes to sleep apnea appliances. You can see where it says the E code, durable medical equipment, that's what the oral appliances are now under.
And that's an E0486 is what one of the codes are. And we're going to show the codes in a little bit, but so when we see an E in front of it, it's going to be durable medical equipment, and the D, of course, is the dental procedure, and then it will be followed by the 4 digits of what we're talking about. So let's talk a little bit more about the HCPCS codes.
Okay. The HCPCS codes are the numbers and letters assigned to every procedure that the medical practitioner could do. Again, private carriers sometimes use them, but they were designed for Medicare. for any of the procedures and diagnostic tests you do. So no matter which doctor a Medicare patient visits, they're all going to bill E0486 for Medicare. That's the only allowable code for dental sleep appliances. Okay? And Medicare, they're uniform. They'll pay that doctor the same amount as any other doctor in the same geographic region. There's four different jurisdictions.
Okay, and that's what I was going to just ask. There's four different regions, and
that's
each
correct.
region handles it slightly differently.
That's correct.
Dramatically differently.
They could be similar, and they could be somewhat different. That's right.
Yeah, and so when we talk about this, please note that we're going to, we've got a lot of people calling in across different boundaries, and of course, Medicare is a U.S.-based thing, so we can talk a little bit about that. But really, what I found is the difference is what you brought up earlier, and that's the Icd Code.
That's the International Classification of Disease, and of interest, those were designed by the World Health Organization, not the American Medical Association. The WHO came up with them. Anytime there's a new disease or condition, they assign an Icd code to it. So they are international to keep track of diseases. At the same time, we use those to show the insurance company what the diagnosis is, whether it's sleep apnea or TMD or severe bone atrophy. Okay. So that's probably the biggest difference between medical and dental is that medical does have diagnosis codes.
And so it occurs when a physician, the definition in here, we're going to talk a second about because in medical billing, you have to get a diagnosis code because in dentistry, it's on or it's off. I mean, you take an x-ray and you kind of know what happened. With medical, there's so many issues that are, kind of unexplained that might take a while to fix. Kind of in dentistry, it happens pretty quickly and they don't use it. And so, I took some time and I went through defining what medical overbilling is. A lot of the times we're getting questions about, how do I bill medical? Is it overbilling? Is it underbilling? So I went through this whole section here, and you and I have been through it a time or two, and really to talk about what, medical billing is it overbilling, and what considers medical fraud, and what's considered, normal and customary practices. And it occurs when a physician is billing an office that submits a claim for services and diagnoses serious, basically they're upcoding or they actually didn't do the work. And so the original diagnosis in order to gain great reimbursement. So it's really upcoding. One of the slides that I found, and again, I've gone through the web pretty often, and if anybody has other examples that they'd like to email me, I'd love to make sure that you can email them at info@1800snoring.com if you have other examples or things that you might want to talk about. Overbilling in the medical world, I recently read a national paper statistic that said on average, hospitals, and again, this is an example of hospitals, pay only 44 cents on the dollar for medical insurance and about 22 cents on the dollar for Medicare. Now, this is medical's ball game, and it's their rules. As we all know, that you need a medical letter of necessity and a prescription from an MD for you to actually do this kind of work. And that what we're going to go through here is we just kind of need to understand that it's really we're playing in the medical game, and we need to go through this to be fairly compensated. And so let's go through some slides here and talk a little bit about what I've seen as far as billing errors and overbilling and what they consider overbilling in the medical industry. And it's really doing work without basically a written certification or basically that diagnosis code for illness is what we see Kaiser getting hit up for here in this slide.
Okay, yeah, that's interesting, isn't that?
Yeah, and then I saw here is Allstate, sues California doctors and seeks $16 million back, but if we see why they did it, it's because of alleged upcoding and billing for treatment never rendered.
Well, Larry, that's why your documentation is so important.
And that's why we're going to really spend some time on documentation. I mean, look at it. We've got some slides here, but, the medical industry says, look at if you charged, some code that you shouldn't have, for something that you did, that's where it's going to be, or for treatment you never did. I found this really interesting as I went onto Wikipedia, and this is how interesting and why we have so many people on the line today is if you look at Wikipedia and typed in medical billing or medical fraud billing, it says, providers typically charge more for services than what has been negotiated by the doctor and the insurance company, so the expected payment from the insurance company for the services is reduced. I mean, this is a practice that they do in medical all the time, and and it's so not what we do in dentistry.
Yeah, and I can see why it's so confusing to people because it's a lot different than what we do in dental. And here it says it's been negotiated by the doctor, but they charge more than what they negotiated. So I think that's very confusing, and that kind of shows what's out there, the kind of information that you get when you go searching for this.
Yeah, and it's just, I mean, this is what they show on the net here. So I went back to some dental sites, and I said, okay, well, what does dental think of this? And it's really, hey, if you waive the copay, you're really creating an advantage, and you're really not charging what you should have been charging. And again, in dentistry, if you don't charge the insurance company what you would normally charge a patient, if you charge them more, which is what would be happening if you didn't take their copay, that's really considered really what they call medical billing fraud. And it even says here, and I highlighted it in red, other suspicions that your dentist might be overbilling. Call us now. I mean, that's where you call the hotline. So I went on to StopMedicareFraud.com, went to NHCAA, National Healthcare Anti-Fraud Association, went to a few different other websites, made a bunch of phone calls, and really it's interesting to see how the medical industry considers fraud versus how the dental industry considers fraud. Dental industry considers fraud, when we might be overcharging, and in dentistry, in medical, it looks like here's on Anthem's fraud report, and I think everybody has the screen up now. Billing for services supplies that were not furnished, altering claim forms to receive a higher reimbursement, soliciting offers or receiving kickbacks, bribes, or rebate. Really, that's more the Sark's law on that one, and altered prescriptions or medical bills, is what they consider that. And so really, let's talk about this slide, Rose,
Well, all right, so you're asking to get reimbursed with medical billing, do you have to charge over and above what you desire as a fair fee? Generally, we recommend that the doctors we work with charge a fair, reasonable fee, and you'll generally get paid 80% of what's usual and customary. So.
And so, yeah, that's really the big question that we get asked a lot is, and I know we both have answers to that, is do you really have to do what you're doing in the medical industry? I mean, here's what the medical does. I mean, 22 cents on the dollar, 44 cents on the dollar. You're now saying it's really 80 cents on the dollar. And I know when I've gone to a hospital, we had a hospital visit the last time. It was $30 for that toothbrush that they charged.
They probably only paid $1 for that toothbrush. Yeah, that's always kind of baffled me. And I know in dental billing that is considered fraud. The biggest difference is keep in mind that medical billing is diagnosis-based. So it's not, okay, you did this procedure, that's absolutely the fee for it. It's more based on the diagnosis given the patient. So they don't have the rule, okay, we're only going to pay for Panorex every 5 years. Based on the need, if you have a patient comes in with head pain and they need a Panorex to check things out, then they'll generally allow that. If they come in 3 months later with something that's a medical necessity, they'll often consider that too. So it's not based on the time. It's more diagnosis-based.
Okay. Well, let's move on and let's say, what can a dentist bill to medical insurance?
Well, obviously, we're here today to talk about the dental sleep medicine. Private carriers will pay not only for the sleep apnea orthotic, but generally the diagnostic records such as the radiographs that you need to take, and exams as well. They'll also most of the time pay for follow-up. And the same applies for the NTI appliance and the TMD orthotics. There are a lot of other things you can bill to medical, such as anything surgical. Bone grafting can be really good for medical. So those are the main things.
Okay, let's move on. So what are the guidelines?
Well, these were created by the Center for Medicaid and Medicare Services and the American Medical Association. If you use office visit codes through medical, just like dental has office visit codes, so does medical for that initial exam and follow-up visits. You have to have a certain level of documentation, not just a note in your chart that you'd say, you know, the patient came in and we did this. If the insurance company were to come in and look at your records even after paying, sometimes in an audit, they have a little check sheet they come in with, and those mimic the guidelines set up by the CMS and AMA. So they're very specific, and that's the good news. I know everyone's now sufficiently scared after seeing all the slides about fraud. But the key is just know what they want and have all your ducks in a row. Okay. So in order for the Medicare and medical insurance to pay, keep in mind they don't want dentists billing dental procedures to medical. They want to make sure it's medically necessary. And, of course, the service must be performed. That's obvious. And documented. It must be performed sufficiently documented to show medical necessity.
Okay. So the service performed must be sufficiently documented to show the medical necessity. It seems like this is the most important guideline for billing services that you're going to render, and that if you don't document sufficiently for the services rendered, as if you did not perform the work at all. That's kind of what I saw in some of those fraud things, and that you could get in trouble over fraud by not documenting these things correctly.
That's true.
And so let's talk about how to document.
All right. Well, when you're sending in claims to medical insurance from a dental office, we generally send something like a SOAP report, and that's a report of medical necessity to show that, yes, this is a medical need. And that's the subjective, I'm sure everyone's familiar with this, objective assessment and plan. That's the method of documentation physicians use mostly. There are other types. And the subjective is, what did we see? What are the patient's complaints? What did the patient come in for? What did we find would be the examination findings. Your assessment would be the diagnosis, or that you think the patient should go see another practitioner. Now, as you know, dentists don't make the diagnosis of dental sleep medicine, but your assessment could be that based on the sleep study and the physician's note that the patient is a candidate for oral appliance therapy. So you're not diagnosing it, you're making that assessment. And, of course, the plan is what you're going to be doing. And so we find that that's a very nice way to send the notes to the medical insurance company.
Okay. And again, I think that's where we should look at it. What do we see? What do we find? What does that mean? And what should we do? So let's get on to some billing guidelines, and talk a little bit more about some of the rules for documentation, because that's really where we see most of the difference in the medical billing is how do we document what happens. Okay.
Yeah, the specific date of service should have that specific documentation I was mentioning before, the check marks from the American Medical Association and the CMS.
Okay, and what I've seen, and this is one of the best ways to articulate it that I've seen, is that Medicare has a specific stand on documentation, and we'll just use Medicare and just put in any medical insurance company. If it is not documented, then it didn't happen. If it cannot be understood, then it didn't happen. If it cannot be read, then it did not happen. If it didn't happen, then it should not have been paid. And if it was paid, then we'll ask for our money back. And when they ask for their money back, it's never at face value. They're always asking to attach it with a very big penalty clause. And so let's talk about what happens if they did get paid, Rose.
Okay. Well, I guess, just like we were saying, just because you got paid doesn't mean that everything was documented correctly. The good news with medical insurance and Medicare is we do now know exactly what type of documentation they need, so we can help you with that. They generally audit only after they pay you. They don't audit before the payment. So they'll come in or ask for records post-payment, and in some rare cases I have seen that the insurance companies have asked for money back just based solely on documentation or lack of. And, so that's the only thing that shows that you've actually performed the work is your documentation. I do also recommend, in addition to making sure that you have everything that they need, is put the time spent with those patients for those office visit codes. If you spent 30 minutes, the patient was in the chair for 30 minutes, indicate that, or 45 minutes or 60 minutes. Okay.
And then let's talk about really going through the rest of the documentation guidelines here and explaining. Is this how does this work in?
Well, it's also important to make sure that you explain the rationale of treatment, you go over risks and side effects, and document all of that. So it's like an informed consent. If you have a really nice letter or report that you send to the patient communicating the proposed treatment plan or something they can take home, that's important. It's also important to communicate back with the prescribing physician. So we take these SOAP notes and actually suggest that you turn them into an actual letter or a report, I guess, back to the prescribing physician. Any referring doctor, primary care physician would be important too. And so, the documentation has several advantages. You can communicate your treatment plan with the patient and physicians, and it helps you get paid in a timely fashion as well.
All right, I'm going to ask the big question for you, and the real question is this: I know you have a software called Dental Writer. Why not just Fix or EagleSoft? Why should somebody buy a separate medical billing program and you can read the rest of it?
Is that redundant? Is that redundant? Does that mean being redundant to have two programs, I guess?
Exactly. And so, what made you decide to come up with Dental Writer, and what is it? Because we're going to talk the next sections about it.
Well, we find that the best way to provide the documentation is to have a program dedicated to just dental sleep medicine and TMJ. And the reason for that is the general dental softwares are not set up to provide that level of medical documentation, the exact questions you need on the questionnaire, and of course when you do the medical history taking, and the exact check marks you need in the exam as well. So I think documentation is one of the biggest reasons for that, to have the right letters to send to physicians and insurance companies too. Also, as we mentioned earlier, training the team in medical billing is always, something that is going to, depending on if anyone has experience with it, it can take some little time. And we find that with a software dedicated to just this, it really, really helps decrease the training period.
Okay, and I think what we've seen is in part of the reason is, and I pulled this up from documentation from Blue Cross of Tennessee, is like, what do you need for documentation in a dental software program? And so in a dental software program, basically all you need is an FMX or some type of thing, and basically what happened, it's really in the X-ray.
Yeah, that's true.
Okay.
There's a big difference.
We're getting a lot of questions, and I will get to some of those as we get through the section. And you guys are asking a lot of great questions, and I'll get to that. But let's talk about medical billing. The questions that people sent me earlier are: can our practice determine benefits in advance? Can dentists bill medical when they're not in network? And I just got that a few questions right now on that one. Do handwritten claims work? And is Medicare different than private carriers? Let's kind of take these one at a time, Rose. And before I go through some of the slides, let's talk a little bit on this slide. What can our practice determine benefits in advance?
Well, we found that when we were doing it as paper claims, it's the strangest thing. I don't know what happens to the paper predeterminations, but they always seem to get lost by the insurance carrier. Sometimes you hear back, mostly, I know you've all experienced this, mostly you don't. We do find with electronic billing, now you can predetermine these claims in advance, which is really nice. Okay. Can dentists bill medical when not in network? There is something, you might want to make a note of this, called a Gap Network Waiver. If there's not someone within, say, a 30-mile distance who can provide the treatment that you provide, there's a gap in the policy. So when you're verifying benefits, or the patient can ask, do you provide the Gap Network Waiver? All right? So that can be really useful. A lot of insurance companies will go ahead and allow that. And sometimes it's really, Larry, just a higher copayment for the patient. Instead of paying $25, the patient might pay a 30% copayment. That's very common too.
Okay, so basically they have to, there's something where you can call and get a pre-authorization, right?
Yes, you can.
Call them up, and we'll go through that. I think I have some signs there.
Yeah.
And, you know, we'll talk a little bit about handwritten claims in a little bit. And medical, I actually have a slide on that. So we'll come back to some of those questions. I think some of the things that people are asking, and we want to get back to that. So let's talk about the documentation you need to submit for pre-authorization.
You'll need a copy of the sleep study, a physician's order, or LMN, which is letter of medical necessity. If it applies, the affidavit of CPAP intolerance, and as we mentioned, your SOAP report.
And on the last question, somebody had asked, Maria just asked, do you have to confirm the Gap Waiver prior to treatment?
Yes. You do need to confirm that prior to treatment. And again, just because you're not in what network doesn't mean you need a Gap Waiver, because sometimes it's just a higher copayment. But if it is a plan you're not in network, I would check into that.
Got it. All right, so let's finish on this slide. So I know we'll get off a little bit. So documentation needed. You need these 4 items really to send in for a pre-authorization. Okay. So let's talk about what the biller should do in getting verified.
Well, you definitely want to verify the patient's insurance coverage. Obviously, you're going to copy the medical card, front and back. You can either call and verify coverage, or now with the electronic billing, that's been working out really good. You're here pretty quick, too. One of the things you might want to ask is, do they have DME coverage? As I mentioned earlier, it's covered under durable medical equipment, so that's a good question to ask. And if they do have DME coverage, is there a cap on the DME?
All great questions, and all should be working on that. And so, what is it that you're writing down when you're documenting these things? Yeah,
there's certain guidelines. The American Academy of Dental Sleep Medicine has some, not as much documentation guidelines, but guidelines in the treatment, which kind of tie into the documentation as well. Obviously, you're going to do an airway exam. You'll always want to do a TMD and an oral screening if you're putting in an appliance. You definitely need that order from the MD in your chart that the appliance is ordered. And it doesn't have to be a sleep doctor. You can actually have the order for the sleep appliance from any type of physician. Even with Medicare, the order can actually, the face-to-face evaluation can be a nurse or even a nurse practitioner. So as long as they see someone at a medical office, that's pretty much the rule. So you do need that order and the diagnosis. Your ICD diagnosis codes, of course, your plan, your CPT medical procedure codes, what the protocol is going to be as part of your plan, and of course that you did go over home care and any side effects the patient might have with the device.
And on that MD diagnosis, if they have a, they have to have the sleep test. I know there's a lot of home sleep testing out there, and they can get signed off by a board-certified physician.
That's right.
And they can work with that. And I think I've seen a lot of the reports. Waterfall is a great one that I see on that one happening. And so I know that happens. And then is that considered everything that they need if they get one of those? And well, with medical insurance, as long as they have the diagnosis from an insurance, Medicare needs the sleep study ordered by a sleep physician and an order from a physician too for the appliance. So, and we have that all written up too. If anyone would like to see the guidelines for Medicare for your jurisdiction, we'll be happy to send those to you. Okay. Okay.
All righty.
Right, so getting started. Let's talk a little bit about getting started. What is it that we need to get started?
Well, speaking of documentation, we find the best way to gather it is obviously through the patient questionnaire and medical history taken. And through the dental writer, there's a questionnaire just for dental sleep medicine. And of course, we've got one for TMJ that's more toward the NTI appliance as well. So you've got your questionnaire, you've got your exam, which provides the documentation for the patient being in your chair. And you take that, and from the questionnaire and exam, you need your SOAP reports of medical necessity. And the last form is your medical claim form. So that's
the 1500 form that we're talking over there?
Yeah, the CMS 1500 medical claim form. Yeah, so those are your tools.
And not only, there's other ways to get it. I know your software is great. I've got a lot of people that may be on the line that says, hey, wait, I'm not sure that I want that yet. But they really should have some other form that they could maybe use, and a manual form before they,
Oh, absolutely. Yeah, absolutely.
What would we talk about for somebody who has who doesn't have that kind of software? What should they be using as far as their questionnaires?
Well, you again, you want to make sure you have a questionnaire that asks the right questions since you are billing medical. For instance, if you're billing a certain level office visit to medical, you need a family and a social history. Well, I'd be glad to send a sample of our questionnaire out to everybody too. And that shows you some of the documentation guidelines there.
Maybe what they can do is if anybody right now wants to get a sample of that, just email us at info@1800snoring.com, and I'll make sure we get you guys a copy of that. So that's info@1800snoring.com, and we'll get you a sample of that to see if for anybody who needs that level of something, and we'll get that to you. So they have the ability to kind of look at this, see what it is, and of course you've done it automated, but I want to make sure everybody on the call can have something to work with.
Okay.
So let's talk about the elements that they need in that. So we've now done the intake, and I think this covers what you were talking about. Let's go into it a little bit more.
Well, these are specific to the AMA, as we spoke. You need to have the chief complaint, something called HPI, which is history of present illness. That's sitting with the patient and having them describe their symptoms, the duration, the intensity of snoring, that type of thing. So there's certain guidelines with that. And just talking to the patient, have you been on CPAP? Have you, been diagnosed? Have you any other treatments? There's the Epworth. That's important documentation, the standard sleepiness scale, and, of course, your sleep study info.
And there's a few different scales out there. Do you see that one or the other gets picked up more by insurance? Or
well, the Epworth is the standard. They ask for the Epworth. Generally that's the standard. There are others out there that some of the doctors we work with like to use more than one. There's something called the fatigue scale and the Berlin scale. But the Epworth is
second one?
It's called Berlin. it takes into account not only daytime sleepiness, but high blood pressure and BMI as well. So that's kind of a neat one. And so, but the Epworth is the gold standard, the daytime sleepiness scale.
Okay. Yeah, so Epworth's the scale, and we've seen that happen a lot. I know that there's other ones out there, and I know there's some people who go, well, it's only this scale, but again, we always know the Epworth's the standard, and I just want to make sure they cover that. So let's talk about the examination. I think we'll just cover this.
I think we already kind of covered that. We just covered that. So, but you know, again, in addition to the other things I mentioned earlier, most of our practices do take the vitals as well. And that's a sample of the examination for the airway. As you can see, you've got your Mallampati. On the left is how high is the tongue above the occlusal plane. Below that is your Mallampati, where the patient sticks out their tongue. And then the different tonsil grades as well. So that can all be part of the airway exam.
Yeah, and what I always heard is the Mallampati is Dr. Mallampati was a anesthesiologist, and that was really a class of intubation, and that how open the airway was and how much you can intubate it is also something we've been using in the sleep arena. Let's go, and I got a question, so let me go to some of the questions and see if we can get some of these answered. And I thought there was something pertinent here. Let me just make sure I go through that one.
Okay.
One of the questions says, do you have to become a DME provider to get paid for DME codes? If so, we'll talk about how to become a DME. I think we have a slide on that later, but how do you answer that?
Some of the private carriers don't require you to be a DME provider, and some do. With Medicare, in order to bill Medicare or even see a Medicare patient, you do need to become a DME provider. With private carriers, it varies. It does vary.
And we already asked the Gap question. One of the questions here, and it's a great time to just look at it, we'll come back, is Dr. Stephen Keller asks, should a dentist ask to get in network, or is it a nightmare if he is, and if so, how?
Yes, Dr. Keller, actually a lot of the dentists that we're working with are now becoming in network with medical plans. And I think it's a really good time to do so. With Medicare deciding as of January 3rd of this year that they'll be paying for the sleep apnea appliances, it's a great time to start working with the networks. Now, you will negotiate a certain fee per patient, which in some ways, if you're okay with that fee, makes it easier because you'll know what the patient will be reimbursed. So, yes, I recommend it.
And a lot of members are moving forward with getting in network so that you don't have to fill out the Gap exemption, because if they're already the ones in network, then they will. You don't have to always worry about those.
That's right. And you want to go straight to the medical director of the insurance plan, especially if you fill out the form to become a provider and you're not having any success. Try to go straight up to the medical director and contact that person.
Okay. Well, I have a follow-up question for if you'd like to be, which is the next question we got is, so okay, so you say you should be in network. How do you do it? Let's just, everybody on the thing, I can't tell you how many people just ask that and say, just tell me how.
Yeah, how do you do it? Just tell me how to get in.
And just say, okay, everybody, I'm asking you.
Yeah. Well, we're actually working with an expert who has helped physicians get in network, and some of our dentists too. So basically, you can go online, and you're going to, I can send you a list of things that you need to gather before you go online. We have that list available. And you go online and apply to be a provider. And lots of times they'll say, no, we don't need anyone, or we don't have a dentist as a provider. And the big key is to just be persistent. Again, go up the ladder. get in touch with the medical director, send letters, you just really have to be persistent.
Okay,
but
we just had everybody. Send back the question. Says, you got my email from the last thing. Just send me that too.
Okay.
You know,
I think I'm making a list.
This is a fat email I'm sending out.
Yeah. Okay. Yeah. We'll definitely. I'll be happy to send that.
No more questions on it. I got it. It's going to be sent out too.
Just send me the email. Okay.
So it looks like we've got a big email packet going out. So what do we talk about to the patients? And by the way, we've had similar things where we've got a lot of our members going in network now, and we have a great place, and the questions will be there, and I'll add it to my list of things that we do to help us. So discussing insurance coverage with patients, always going over the financials and estimating insurance coverage, and then getting the patients to sign off on it.
Yep. Yep, definitely go over the financials.
And a part of the reason we had you come on today is not only are you the queen, but really when you go electronic, getting your pre-authorization back, the difference in time is amazing from doing it manually to getting it electronic. Why is it so different, and what are you filling out that's so different electronically that they can't do manually, and why do I see such disparity in a lot of claims?
Well, that's an excellent question. I just see a big difference now that many practices are doing it electronically. For some reason, I don't think medical knew what to do with the pre-auth if they were manual, because I think that's more of a dental thing. So the electronic is just, the way the insurance companies seem they receive it. You can see that they received it, and if they need more information, if you send the pre-authored the claim electronically, they'll usually send you a fax number then to send the data to, the sleep study and the SOAP reports. So it just makes things easier. Yeah.
All right. People just asked. The email again was info@1-800-snoring.com. That was the email. And so we talked about the Gap Waiver and being out of network, because, again, we're going a little bit through here. And I'm going to speed us up just because I know we're going to get to one section where we're going to get really stuck on. But let's talk about the Gap Waiver. I think you talked about it a little bit.
Yeah, and again, the insurance company may give written permission for the patient to receive benefits from an out-of-network provider. It would be, of course, at in-network rates. And that's, again, if there's no qualified provider within a reasonable area. So it's called the Gap Waiver or the Network Waiver, sometimes Gap Exception. So it's something important to know about.
Okay, so that's a Gap Exemption. And the other question that came up is, how do you get in with Kaiser? Does Gap waivers include Kaiser? I think I heard that they may not accept Gap waivers, but that's something I'd have to look into for you. Okay, we'll land that. Let's go to the next slide, because we'll do that. So can we? Here's a slide. I guess I talked about it earlier. How long does it take? Do we really want to be one? And I think you already covered that.
Yeah.
Do they get paid quicker?
Oh, absolutely. Yeah.
And what kind of fees do you think they negotiate versus being out of network? Is it a 10% gap, a 20% gap?
It just depends on what you negotiate with them. And, it does vary a lot depending on the area of the country that you're in. So I see usually, I'd say it's probably about 2/3 average of what your normal fee would be if I had to come out with an average. So, but it depends. It varies, in the area of the country you're in and just by insurance company. Oh, there you go. That's medical claim form, the 1500.
Yeah.
Okay,
that's a claim form that you'd fill out, or it's done electronically. And here's what I saw: electronic versus paper claims, what people get paid, which is astoundingly different.
Yeah, we had someone say they're getting checks in 7 days, which isn't always the norm, but and it's put straight into your account, so that makes it really nice. And as you can see, paper 45 to 90 days, sometimes 30 days or sooner, but it does take a lot longer. And the nice thing is electronically you can track and see that they received it too.
Okay, and one of the big questions I always get is, when do you bill the insurance? Is it after the impressions are taken?
Well, that would be being the early bird.
Yes, that would be.
Yeah.
But is it proper? Is that
no?
Right?
You would actually bill for the appliance when the appliance is seated on that date.
Okay, so people ask that question. So you bill and you would bill when it's seated and they've received it and taken it through. If they didn't.
After the patient has the appliance. I did see in some of the Medicare things that if you actually make an appliance for a patient and they don't come in to get it, you can still bill Medicare. So I thought that was unusual.
All right. And one of the questions that I have coming up is, can I have the patients pay me directly and have them get reimbursed with a check directly from the insurance company, leaving me out of the loop with the insurance company?
Yeah, absolutely. You're going to have the patient pay you. That's called a non-participating provider. Now, I believe she's talking about Medicare. There's two types of providers in Medicare: participating, where you accept assignment, and non-participating, where you can have the patient pay you and the check goes to the patient.
Okay. And can they collect the copay before the appliance is delivered?
Yes, you can collect the copay before it's delivered.
Okay. Peter, you got your answer. I don't think I've ever had this many people want to ask questions, Rose. So
Well, these are excellent questions. That's my favorite part is the question answer, because that's.
How do you send electronic claims when the info that comes from the physician is a fax? Do you e-claim the included attachments?
It turns out that sometimes the insurance company will accept attachments. It depends on the carrier. But what we see a lot is when you send it electronically, the insurance will then send you a fax number to send the documents to. So you'll go ahead and send it electronically and then fax the information over very commonly.
And usually put some form on the top that will allow them to.
Well, they know it's coming in, and you actually have a number to attach to it. So.
All right, this is probably the biggest slide we're going to be on. We've got about 7 minutes here, and some of the questions that I always get is, do I bill one fee? And in dentistry, we always, used to billing one flat fee for no matter how many visits it takes. And in the medical industry, basically every time I go visit my doctor, he charges me for an office visit. A lot of times I get the question is, which is it? Do I bill one flat fee? And so if I'm billing, like we have here, the E0486, the E would be the durable medical. Can you not bill for anything else? And let's talk about the difference between medical insurance and then Medicare.
Well, these are things that ranges that I think we see medical paying as opposed to telling you what to set your fee at. Let's talk about Medicare and medical insurance with the E0486. Medicare wants you to bill everything in one code, and so in fact you're going to bundle everything into one code. Whereas private carriers at this time are mostly letting you itemize things, which would mean when the patient comes in for that initial appointment, you would have a code for that office visit. If that's a screening, just a short consultation screening, you may even have them back for a history exam and workup where you take the impressions, and so that's billable. The radiographs are very good for medical. They're very used to receiving x-rays and dental radiographs from a dental office and paying for those. So the Panorex, generally often a full mouth x-ray, and a Ceph as well, many times. Let's see. And then, of course, private carriers, then you would bill the orthotic as a separate claim, and then when you deliver it, and then the follow-up appointments too. Some practitioners allow a certain amount of follow-ups in the cost of the appliance, but Medicare, in 90 days of follow-up is included. So it's a total bundle: the exam, radiographs, the device, and 90 days of follow-up in Medicare in one code.
And we can talk about Medicare because it's the standard fee. In one of the in one of the regions, people are getting paid $19.55, including supplemental. Is that about right?
Yes.
And so,
through
so
Medicare.
For Medicare. And so
Medicare.
What I've been seeing a lot of doctors do, and again, we're not here to set fees. This is a range. I have seen these ranges that doctors have done, and so we're not here to set fees. Please, anybody who's seeing these numbers, these are just what I've seen out in the arena. Rose has seen them out there. Here's the kind of codes. There are a few other diagnostic codes. We are not telling you to always use these codes because, again, sometimes it's not this and you don't want to up code. So we're just saying here's what we see mostly for this, but there are other treatments in there. And so please know that when we're showing this, people had asked to say what are the ranges that people are doing, and you got to decide where you at in this range because like what you said, Rose, is you're seeing when you bill, you're putting your fee in here, and then insurance is paying about 80% less, and sometimes even less than that based on the insurance.
So, that's right.
Okay. And some of the people have asked, you know, that, let me go through here. What's the applicable code for the NTI and for migraines?
Do we have a slide on that? Oh, the diagnosis code?
Nope. Yeah, what's the diagnosis code?
Well, as you can see on the bottom, the sleep apnea diagnosis given by a physician is 327.23, and then the 524 for the TMJ code, 524.63, that's for actual TMJ disc disorder. Yeah, so any type of disc disorder with the TMJ, that would be appropriate.
Okay.
As your diagnosis code, not your procedure, but your diagnosis code.
And yes, I did say $19.50 is what Medicare in certain regions are paying for the E0486 for that inclusive code. So I hope that answers that question again. For
inclusive,
you guys. That's
right.
It's an inclusive fee on that one. Stanley, I think we answered your issue on the NTI.
Okay.
Are you held to Medicare fees if you are a non-par provider, or can you charge your full fee for the appliance?
Okay. If you're on Medicare as a non-participating provider, you can charge your regular fee to the patient, and then Medicare will send whatever they pay to the patient. So you would not accept assignment on those claims. You would make sure it was sent to the patient. The check was sent to the patient. But yeah, you can charge your regular fee as a non-par provider.
Got it. Okay. The email, I will promise you I will repeat again. I have a slide on that one. Some of these questions are just funny. Okay. My email's acting up. Please send the information to Rose. Okay, so let's put it all together. We've got about 5 minutes left. I think we've gone through a lot of questions here. Basically, putting it all together, you need the OSA code and an oral appliance code. I think we've covered that. You need the medical letter of necessity. You need the description about the appliance, which one it is, and of course, Keller carries great quality ones, the TAP and the EMA. You need the prescription from the MD, and you need your narrative. Some of these documents are available at kellerlabs.com, and of course, some more comprehensive integrated documents and services can be available through using Dental Writer. I do want to mention that Keller's Crystal Clear Communication team is always available to discuss any of their specialties. They have TAP, EMA, NTI+, the night guards, the thermofits, and they're always available. And I've had my clients work with them, and they're fantastic in helping them go through getting a case taken care of. Let's talk a second about Medicare. I know that people asked about it, and I'm still getting questions on that. And that's in order to get paid by Medicare, again, in network, you do need to become a DME.
That's correct.
And you need a Medicare place of service, so including oral appliances. And again, we talked about it's a bundled fee. We did talk about that DME is in 4 regions, and new as the it now covers oral appliance as a first line without the need for a CPAP. Prior to January 3rd, you had to have a CPAP affidavit, basically saying you that you failed on CPAP before they would let you get an oral appliance. But now, for mild, moderate, in certain cases, they're allowing that in. So it is provided, and of course, it's simple once you're connected. I know I did ask you this, and so people were going to ask about it, and so I did make sure that if you are looking to get your DME, it's easy. We have a program with Rose on this one, so together we have a program where for $15.85 you can get this all taken care of, and the paperwork's filled out. How many pages is it, Rose?
It's 39 pages.
And I know that people have a problem sometimes doing it.
It's pretty complicated.
You can do it on your own.
Yeah,
and,
you can.
And a lot of people want to get it sent out because if you cross a T wrong, dot an I, it just takes a lot of time to get it done right. It is on a first-come, first-served basis. I know we've got a lot of people on the line, and so
and the good news, we've actually been seeing some of the doctors getting approved within 2 or 3 weeks. So some of them take longer. I don't know why, but you should be hopefully within 60 to 90 days is what we were told, but we've been getting some back within 2 or 3 weeks, so that's exciting.
Okay. And do we need to contract with a clearinghouse to send bills to Medicare?
Yes, actually, if you're going to do electronic billing, you can you would go straight through. You can do it right through Dental Writer. We have a partnership with a electronic clearinghouse. So.
Okay, and so Dr. Carstensen, I hope I answered your question. Richard wants to know, how long does it take to get paid from Medicare?
Generally, you should see within 3 weeks to 30 days. They're pretty good. If everything's there that they need, it should take 30 days or less.
Okay, Dr. Keller is being funny. Signing up for Medicare requires a PhD level, but I did it if I ain't easy and need a formal template to get it done.
Okay.
So again, somebody wants to know what the cost of Dental Writer is. Okay,
I think we'll get to them.
Because you have that right now, and you can talk about what Keller did on this one.
Okay.
And, Keller is helping out on this one for their Keller clients. You do need to be a Keller client for this deal.
Okay. Well, this is the Dental Writer, and as you can see, you can the patient could fill out the questionnaire online from your website, and the data downloads into the Dental Writer software, or they can fill out the paper questionnaire. So you simply plug in the findings from the questionnaire on Go with the Flow. Number 2, you would enter the exam findings, and it generates your diagnostic SOAP reports to communicate with MDs and medical billing, of course, medical necessity. And when you say the diagnosis and plan in the exam, not only does it generate your reports, but it links the right codes to the medical claim form. And then there's another module, which is called Crosscode, just like it sounds. You can click on the dental code, and it shows you the medical codes. And there's about 80 examples of how to build different things through medical in number 4, the Crosscode. The Dental Writer, it's normally $40 $54.95 for the software, and what we're offering is $39.95. That's a Dental Writer online 3-month trial, and also would include the 3 months of the medical billing and coding hotline. So that is a savings.
Yep, and thank you, Keller Labs, for twisting your arm to do that and getting you taken care of on that one as a thing. Anybody wants that, it's Rose at dentalwriter.com. That way she doesn't have to pay any commissions to anybody or whatever else you do.
Okay.
And of course, so you have it directly. And of course, it wouldn't be me as a marketing guy if I didn't have a blatant pitch for what we do. And so thank you guys for attending. But we do, if you are looking for more snoring and CPAP intolerant patients, we have programs. It's a 100% proven method to get broadcast television working. We're getting unbelievable amounts of calls. And if you are looking for introductions to medical professionals in your area, such as MDs, sleep labs, DMEs, to talk about CPAP failures and just doing oral appliances, we do that, and we include case acceptance and coaching for the team. You got $1,500 off. We went with a $2,000 off on the program. And it's in qualified areas. There's a lot of areas where we're getting so much consumer response that we need people right away who want to do this and who can help those patients. If you do, you can reserve a spot at the number below, and again, info at 1-800-SNORING.com. A lot of these have timed offers. It's good till the end of the month for that. But this one's a great deal, and Keller offered this, and Keller Lab has dental sleep medicine. It's their in-office marketing kit, and if you don't tell your patients what you do, then they're not going to be working with you as much. And so this one includes samples of an EMA and samples of a TAP. So that's the sample of a TAP is usually just a few $100s by itself, plus you get coupons off. And it's usually $199 for this one. And they also have the NTI Increasing Case Acceptance Marketing Kit. So between the two, those kits come with the video, 3 samples, so you can show it to them. And Keller is doing, you're going to get both of these kits, a $298 value, both for only $69, and that's good just till Friday. So again, these are because you guys came on board, you wanted to be online, you email Keller at kellerlab.com, that's Keller at kellerlab.com. We have another upcoming webinar coming up. It's how to understand a sleep study. It's using a sleep test to get to yes. We are using myself and Dr. Lee Serkin. Dr. Lee Serkin is a board-certified sleep doctor, board-certified cardiovascular doctor, and part of the American Board of Bariatric Physicians. It will be an interesting topic to talk about on March 23rd at 5 o'clock. And if you wanted to watch our recorded webinar, we have it at 1-800-SNORING.com/Keller-webinar, and that was the first one about identifying apneic patients in your practice. We have a few more questions. If anybody wants to stay on the line, we're going to try to get to some. Can you send more than one diagnosis code?
Okay, for sleep apnea, you'll only need the one for obstructive sleep apnea. For the NTI, you might have your TMJ code as your primary, and then your secondary code could be head pain or facial pain. So yes, you're allowed up to 4 diagnosis codes on the medical claim form. And okay, other than sleep, it's usually good to have more than one.
All right, and Richard wanted to know, what if I become a Keller Lab customer? You'd be very happy. We have billed insurance for patients who have suffered injury from the past. Could we use Dental Writer for that?
Yes, you can bill anything medical through it, through the Dental Writer software.
Okay. Keller webpage doesn't have a simple access form. Do we have to register to obtain the forms? If you can't see it, you can email Keller at Keller Labs. You can email me at info@1800snoring.com. I'll put up a page in a second. Either way, we will find the way to get you information. Have you brought this program, 1-800-SNORING to Northern California? Yes. Call us. What is the cost of dental writer? We covered that. I hear you have 2 years to pay. I'm not sure what Richard means by this, but Richard, I heard here they have 2 years to pay. I think we're talking about Medicare or insurance.
Mm-hmm. Oh, okay. Yeah, I haven't seen that. No, it may be in the rules, Dan, but we see them getting paid a lot quicker than 2 years, thank goodness.
Yeah, I think so. Okay, how long does it take to get paid by Medicare? We covered.
Yeah. Mm-hmm.
We covered the clearinghouse. I think we have covered most of the questions. If anybody has any last questions, I'll take a quick look. Type quickly because I'm getting to the bottom. Thank you very much for the information, Rose. What did DX code 750.57 for sleep apnea?
Oh, that's, I think that's the hypersomnia. And that's not the one being used anymore. It's the OSA 327.23.
Okay, so that's an outdated code.
It's still available, but they want the OSA code now. That's what the insurances want, and that's what Medicare will only pay on that code, 327.23.
Great. Here's a great question coming out from Alan. Can you bill medical for primary snoring?
You can bill, but they probably won't pay.
That's exactly the answer I've heard over and over and over again. Yeah, you could try it.
Yeah.
Okay. We're going to get more info on becoming a PPO with medical companies. We'll be sending emails out on that. Can you use your software? Can you use your software to bill medical insurance for oral surgery? The answer was yes on that, I believe.
Absolutely.
Can I please bring the list of codes back on the screen? I will do that in a second for you. And how do you obtain a DME provider status for your payers? Medicare has the application for DME. What does private have?
We found some of the Blue Cross Blue Shields require a DME to bill with them, and it's just simply another application. We find other carriers will let you use your Medicare DME to bill, and some of them don't require a DME. But it's the Blue Cross Blue Shield you might have to get another one for. And it's just very similar paperwork to what the Medicare is.
Okay. Can one bill medical codes for oral cancer screening?
Yes, there is an appropriate code for that, for the Veloscope.
Okay. Do we have a diagnosis code for snoring?
There is one available. So let me see if I can bring it up real quick here. Just take a second, so if you want to go to another question.
I'll have hands over here. So what if the patient has hypersomnia and not sleep apnea? Do you still bill 327.23?
Well, you bill what comes back on the sleep study. If that's the diagnosis that came back, the sleep apnea with hypersomnia, you can certainly bill that because it did come from the sleep study. Medicare will only pay for the OSA one.
Right. So Maria, the standard reply would be is that you're not picking the diagnosis code.
That's right.
Medical doctor, and we have to take this over again. The medical doctor is picking it. And so with that, I think we've done, what was your answer on that one, Rose? And I think
you use the code that comes on the sleep study.
Okay.
Use the ICD diagnosis code that comes on the sleep study.
Okay. And let's go to the...
Oh, the snoring code, the diagnosis code for snoring is 786.09.
Got it. And this last slide, I forgot to change it. It's rose@dentalwriter.com. So if you have any questions or anything that you need that we didn't answer, email me at info@1800snoring.com. We will get you the information you guys need, and we'll get that taken care of. Rose, I want to thank you very much for an informative 1 hour and 15 minutes. I want to thank Keller Lab. Keller, you guys are great for sponsoring all these and having such an engaged audience. Thank you, participants, for being on the line. We will put this up in just a little bit as a recorded webinar. And thanks everybody for joining. Have a great night.